Hello, everyone. Welcome to another subspecialty VMR. Today, we have very special guests who have been before here with us, but again, bring a great ID case. And as our discussant, we have Dr. Laila Woc-Colburn. Hello, Dr. Laila. Would you like to introduce yourself and tell us a little bit more of you outside of medicine?
Hi, everybody. I'm Laila Woc-Colburn. I'm an associate professor at the Division of Infectious Diseases at Emory University in Atlanta, Georgia. I'm from Guatemala, as some people might have expected. I'm also from Panama, so I have to claim Guatemala and Panama, or else my mom will be very upset. My focus is transplant, infectious diseases, and tropical medicines, and medical education and mentoring throughout Latin America. What I like to do on my spare time is run. So I was telling everybody that I have the Houston Half coming up this weekend. So hopefully it won't be too cold, but I already saw the temperature is going to be like 40 degrees Fahrenheit. So it is going to be cold. Big thing that I did last year was to run the Paris Marathon, which was like one of my bucket lists. So
You've got this, Dr. Laila. I'm really sure that you'll do great. And next, we have our case presenter, Dr. Natasha Spottiswoode. Hello, Dr. Natasha, would you like to introduce yourself and tell us a little bit more about you outside of medicine?
Sounds great. Thank you guys so much for having me. My name is Natasha Spottiswoode. I'm an infectious disease fellow at UCSF, the University of California, San Francisco. I focus on novel diagnostics and bringing new therapeutics to improve patient care. Outside of work, I have discovered the amazing sport of backcountry skiing. And so I spent a lot of this weekend exploring Mount Shasta during and after a snowstorm. And it's given me a wonderful freedom and sense of confidence on the mountain. So would recommend.
That sounds amazing. Now I'm feeling like a couch potato because I don't run and I don't do skiing. So maybe next time that we meet, I will also share with you something sporty. Now we can start with the case if you want. I think Noah is the scriber today, and Amalpreet is doing the teaching points. So let's start.
Yeah, absolutely. So your chief complaint today is headache. So your patient is a 55-year-old gentleman with a 30-pack-year smoking history and hyperlipidemia who is presenting with a headache. To flesh out that history a little bit more, 3 months ago, he developed a sort of vague discomfort, malaise, and fatigue. Noticed that he was able to be less active in his job as a construction worker. He did have some night sweats at the time and lost 20 pounds over the last 3 months. He had an outpatient chest x-ray at a different hospital system, which showed long nodules that were called as concerning for malignancy. 2 days ago, he developed a severe holocranial headache and double vision and presented to the emergency room. I'll pause there.
all right. Let's see, I omitted myself. Yeah. Okay. So so just looking at this, always my question is the patient immunosuppressed or not? So HIV versus non-HIV. That will dictate how I go through it. And if it is, so that would be one. Let's say that is someone that is here in the United States. When you talk about the global north, meaning the developed nations, when you talk about smoking and hyperlipidemia and headache, the first thing you're going to think is cancer, cancer, cancer. But if you go to the global south, and if it's someone that migrated from the global south, or you will always have some infectious causes there, and cancers and malignancies kind of fall very down the list. So he has constitutional symptoms. So he has the malaise, the fatigues, and the 20-pound weight loss and the night sweats. You could say that we don't have a fever, but you can say maybe he has B symptoms, right? So he also has nodules. So you have now nodularities in someone with constitutional symptoms. So you start thinking of granulomatous diseases. So endemic fungi, NTMs, TB, kind of things like that. You know, and things that can go to the brain, obviously, all of them can do. So we'll need to know a little bit more about if their HIV status or immunosuppression, and two, a little bit more history of what's going on and where's the patient from.
This is amazing, Dr. Laila. I just have a little question. Would your approach would change, as in making it more urgent if this patient was immunosuppressed? I know it sounds like very much obvious, but sometimes maybe if we're thinking of a fungi, sometimes I think, well, what if this person that is also immunosuppressed may have mucormycosis? Should I put him like, as far as I can, as quick as I can on a CT scan, or if there is something that will make you take a much urgent approach?
So definitely, Jasmine, one of the things that I'm worried about is this headache, right? Mm-hmm. So it is a severe headache, presents here, and this is not to be inappropriate or anything, but males tend to go to the doctor, construction workers, because they don't want to lose a day of work, go visit an ER. So the headache must be excruciating enough for this person who's a construction worker leave their site and spend a day in the ER, because you're going to lose 1 day of wages, right? Or more, depending. So just having the headache and this constitutional actually would prompt me to do a CT head. I mean, you could have things as benign as, you know, subarachnoid hemorrhage, you know, that has nothing to do with the whole case that Natasha has put this, and it's a red herring, right? But he has a headache enough that has made him leave work, and that you should be concerned before you start doing the differential.
Thank you for that. It's very interesting. I had completely glossed over the social aspect of our patient. So let's hear more about it, Dr. Natasha.
Of course. So let me tell you a little bit more about this gentleman. So his past medical and past surgical history, has hyperlipidemia, and he's had a cholecystectomy for his past surgical. It is true that he's not someone who sees doctors very regularly. For meds, he takes atorvastatin only. Socially, he works in construction, and he recently did a church demolition with findings of rodent and bird droppings. He has family in northern Mexico, where he travels yearly. He lives in Northern California, and he does live in a fairly rural area and has contact with farm animals, including horses.
Sorry, I was like, it's reading like one of those board questions that has every single risk factor.
I'm sorry.
That's no, it's good. It's good. I'm sorry, I laugh. It's just like,
no, it's fair.
I'm like, oh yes, this is my board question.
This case was a little bit of a board question for me as well. And he does have contact with cats. Things that are not relevant to his case is he absolutely says that he has never used drugs, and certainly never anything infectious. And in terms of sexual behaviors, he is married and is monogamous with his partner. Family history is unremarkable. No one in his household has been ill, and he has no allergies to speak of.
All right. So sorry about that. It's just that it has
I agree.
Everything that you have told me is like it's like thinking of more questions. So with what Natasha gave us, so now we have a 50-year-old that, you know, we'll divide it in infectious and non-infectious causes. So it's a 55-year-old man with a 3-month history of malaise, fatigue, night sweats, weight loss, and headaches and lung nodules. That's kind of the overarching. So the easiest one is the non-infectious. So cancer, you know, maybe autoimmune, but likely cancer. The non-infectious, the infectious part is where all this fantastic ID risk history has come. So constitutional symptoms, lung nodules, and a headache. So we talked about endemic fungi, right? So first thing, Natasha told us here is this rodent and bird droppings. Well, rodent, usually I think are more of a kind of a chronic meningitis, so not so much, but the bird droppings, definitely cryptococcosis and histoplasma. Then she says that the patient lives in Northern California. I'm assuming we don't know which part of Northern California, but somewhere in Northern California and Northern Mexico. So if you look at a map, that's what I call coccidioidomycosis country. One of the big researchers on coccidioidomycosis, Jay Thompson, is at UC Davis, which is Northern California. So we have coccidio endemic mycosis for the West Coast. Then you also still have histo. Histo continues to be there. Then she kind of drops a little bit about cats and then think, well, what cats do. Usually kittens is usually what I think. Not so much as lung nodules, but you can have as an acute toxoplasmosis. Masses will come more if they're immunosuppressed. You have kind of CNS toxo-like lesions, but that's it. And then Bartonella, but Bartonella doesn't leave you kind of, gives you nodularity, but not exactly lung nodules. So we have, I don't know if this is the correct term, Easter eggs, lots of Easter eggs around here. So constitutional symptoms, lung nodules, and a headache, endemic fungi, either coccidio, crypto, histo. And, we'll see what else we kind of said. Oh, he's a construction worker. I'm not going to, so that's another one for coccidio. In San Luis Potosí, which is in northern Mexico, in the area of the desert, there is they do a lot of mining, and so there's always an excavation. And so when the winds are the right time, you have this acute valley fever in coccidio, everybody gets there. So that also is another thing to think about construction. You don't think so much as aspergillus, unless you would think more of molds and things like that from that part. So that's so far what I have.
That's amazing, like great approach. I really like the way that according to the localization and where the patient has been, you can also like pin down what could be our main suspect. But yeah, like Dr. Natasha, I'm wondering how the vitals and the exam is looking.
Absolutely. Let me give you the vitals and exam, and then we'll go from there. So he is a febrile temperature is 37.2. His heart rate is 84. He's resping 20, and his blood pressure is 140/80. He is setting 98% on Romer. In terms of his exam, he is a somewhat chronically ill-appearing gentleman, thin but not cachectic. And the other notable points of his exam are that he has a mild diffuse wheeze in all lung fields. Cardiovascular exam is regular rate and rhythm, no murmurs, rubs, or gallops. His abdominal exam is unremarkable. Neuro-wise, he does respond to commands, and he does complain of double vision when both eyes are open. He does not have very obvious neck stiffness. He does have inattention and requires some repetition to follow commands. No rashes or lesions. To give you some basic labs, his white count, I'll let you type, sorry. White count is 5.1. His hemoglobin is 9.5. We don't have a baseline. His platelets are 400. And his basic metabolic panel is normal. His LFTs are also normal. And we have an HIV that was sent by the emergency room, which is negative.
Wow, I did have a question that just popped into my mind. Even if this patient is HIV negative, with this, as you mentioned, with this B symptoms, would you consider this patient as immunosuppressed and from there take it, like dictate your approach, or would it change?
So one of the things I would say, so you could think of if you have an HIV negative, so it's an antigen antibodies of fourth generation, right? This is a screening tool. It's not confirmatory. So you could have acute HIV if you're thinking that, and for that case, we would ask for a viral load. The other thing, and this has nothing to do with HIV, but has to do with CD4s. There are some patients that have what we call idiopathic CD4. So patients that would behave like someone who had HIV, HIV negative, viral load negative, but they have low CD4 and low monocytes. They usually will have a history. They usually are in the teen, in the bimodal distribution in the teens years and then in the 30s and 40s. And they will have a history of recurrent infections like HPV, MAC, things like the crypto, right? This does not fit this case at all, but it's something that sometimes you have to think about, that not necessarily HIV is the only one that can leave you low CD4s and present like this. So the case is getting a little bit interesting, as first as I approached it is with what you have with the history and how you start thinking kind of the clinical reasoning, right? So right now we have a 50-year-old man with constitutional symptoms. We have some lung nodules and this headache enough that he has double vision and this inattention. I guess I would call it a little bit of an ultramental status, or just not, cooperative enough. And then you have mild wheezing diffusely, and he looks chronically ill. So you still think is going to have something chronic. So infectious causes, you still put them in the endemic fungi. You can have NTMs. In the back of the mind is the aspergillus. You have double vision. Does he have like an aspergilloma? Things that are chronic that can also give you that, it's or chronic that can give you that is, if he has a double vision and he has this headache, does he have increased intracranial pressure? Is there a mass sitting in the chiasm, in the optic chiasm? Because it's both of them. And so you have to think about things that sit on top of the optic chiasm. So one of the things that we worry about is sinus venous thrombosis, cavernous sinus venous thrombosis. It doesn't tell us right now. Natasha didn't tell me that he had any issues with cranial number 4, number 6, or anything like that I would think of a thrombus that is sitting there. So remembering your anatomy of what the the cavernous sinus looks like, and what cranial nerves go there. If that's not the case, it's a little bit higher and it's on the chiasm. So you could have a mass sitting there that is putting enough pressure that you could have the double vision, right? At this time, I think, one, we already know he's HIV negative. That doesn't mean he cannot acquire the other things. We also know he's not diabetic. He's at a normal BMP. So diabetes is still considered immunosuppression. He's not in stage renal disease either. The other thing is, so here is where you rely on image, right? So you need a CT chest because you have this X-ray that has some lung nodules, and you want still a CT head or an MRI, whichever is fastest that you can get, to see what is sitting in the head, and if you're going to need to do a lumbar puncture or not, depending on the opening pressure. From the eye exam, I didn't hear that there was any blurriness of the optic nerves to think about, or any edema around it to think of intracranial pressure. And you definitely don't have anything that shows bradycardia or anything that it says that. But at this time, I would go for images, because we don't have too much. We could order a lot of serologies and to rule out endemic fungi, and that certainly would be the case as you get the CT scans of the brain and the chest.
That's very interesting. And now the chat I've seen some comments about tuberculosis. Would you ask for a microscope examination looking for the acid fast bacilli or a NAT, or would you just wait for the imaging?
So yeah, so I mean, so again, we're assuming that we have chronic granulomatous disease, right? And in part of that chronic granulomatous disease, you have TB. So when you think of chronic granulomatous disease, you'll have fungus, so Cryptococcus, Paracoccidio, Histo, Blasto, if you're in this area, right? Those are your kind of chronicity. Then you have your NTMs, being TB, your most common one, and then you have MAC, Kansasii, so you go down the list. Then after you go from fungus to mycobacteria, you go to bacteria, right? So which bacteria can give you? So you have long-term things like brucellosis. Brucellosis is one of those great mimickers that can do that. Things that are, less frequent would be, does this patient, I mean, he has weight loss, doesn't have a fever, but you have this failure to thrive because he's had the weight loss. You always have to think of endocarditis. So that would be on that differential. And then viral, that doesn't give you nodularity or anything like that. And then if you want to go to my world of the parasites, well, you can have things that give you nodules and back. It would be like some parasite like Paragominus can give you that, some Clonorchis, some more like flukes, lung flukes. But again, there would be a history of eating like crayfish in certain areas, and where it's patient is coming is usually not what I would find. So those are the things, but I think the money we need to figure out what the, does he have right now? The worrisome part is that he has the double vision, this inattention. Does he have a mass in the brain that is causing this to have an issue? And do I need to do a lumbar puncture? And then kind of see more what the CT, these lung nodules are. Once you have that, you are going to ask your serological test and your microbiology. So if we're going to go down the route of TB, you definitely can get from the sputum. You can do an MTB, PCR, or a NAT. You will need to have the sputum for that. You might ask someone to bronch and go get something from there. If your lumbar puncture is the same thing, but first you need to know what's going on. The patient right now, if I have to triage, is this double vision that really has me worried of what's going on, because he's breathing okay and everything else is kind of chronic, but this double vision does bother a little.
Interesting. So maybe we can go to the next allocator, Dr. Natasha, to see what happened with this patient.
Thank you so much. This is such a masterful discussion, and it's such a lot of fun getting to see you work through this. Can I share an image?
Oh, that would be great.
Yes, I'm going to try and start share now. Yes, I got it. Okay, fantastic. Give me 1 second, and then you'll tell me if you can see this. Are you seeing this slide?
Yes, the right cerebral.
Fabulous. Thank you. So basically, the clinicians the emergency room team essentially felt the same as you did in terms of triage. And so the patient received an MRI, which I show a slide from here, and I have a second one. But briefly, it disclosed a right cerebellar pontine angle hyperintense mass, exerting significant mass effect upon the right middle cerebral peduncle and displacing the right cranial nerves, including 7 and 8. I show a picture.
Yeah, so when they did the physical exam, they didn't see any, because so the cerebellar, so they didn't see any drooping or anything on the 7th or anything like that.
None is recorded, and I will slightly defer because I came into his case later, so I can't personally speak to it, but none was reported at the time.
Okay.
So a quick clinical update, and I'll show a second image here. So this is a T2 image, and I'll show a T1 here as well. And you can see the mass here.
Okay, so as you can see, so I saw in the chat someone said, neurocysticercosis. The problem with neurocysticercosis is that doesn't give you long nodules, and they are type of what we call cystic lesions. So look, this is a T1, right?
Yes.
So first of all, when I look at this, if I'm trying to look for a cyst, I would like something that its margins are more defined. I hear the margins kind of are a little convoluted. They're not as well defined as that. Then I would scroll through different parts of the sagittal view to see if, and look at the Hounsfields to see if it's water or if it's, fluid versus kind of a mass, right? And then after I continue to scroll, the thing that I would look for if I was looking for neurocysticercosis is what we call the famous scolex, right? So at this time, what I see is from the T1. I usually like the T2, but the T2 looked like it was looked like more more of a mass, a lot of inflammation, opposed to being a cystic lesion. Is that correct?
Yeah, so I can give you a little bit more information and I apologize for not being able to show and scroll through the whole thing. There was nothing that looked like a scolex. It was thought to be, by the radiologist at the time, thought to be most consistent with a simple arachnoid cyst, but one that was exerting mass effect. And so the end of this aliquot that I will give you is that neurosurgery was consulted emergently, given the cyst was exerting a mass effect. And he went to the OR, and a defenestration was performed, which is essentially cutting a window into a cyst to allow it to drain and release that pressure. And immediately post-op, he became quite febrile to 38.5 and had a decreased level of general awareness. And I'll pause there.
Yeah. So again, let's go back to kind of the things that Natasha tells us. So she tells us, so think of if this, it's cyst, obviously there's fluid, as you can see, it was wide. So things that are cystic, something that I didn't hear on that I would have loved to and didn't ask was if in the differential of the WBCs there was eosinophilia or not.
Oh, I'm sorry, there was no eosinophilia. It was a normal differential.
Okay. So things that are so we could look at it two ways. We could say the patient has two processes, the lungs, nodules, and then the brain. Or we can say that is one process together, like we usually like to put everything as an Occam's razor. So we look at it as one holistic thing. Arachnoid cyst, so cystic-like lesions in the brain, and what could be considered nodules in the chest are echinococcus. So echinococcus, we find it in northern Mexico. Actually, we find it also in the US from foxes and coyotes and dogs and things like that. So you would like to see more fenestrations on that, but you could have an echinococcus granulosums, which will have brain and will have lung involvement. So that's the one that I would put together. Other things that give you kind of cyst, or you could have called it purulence if it was the case, and something in the lung, bacterial-wise, is nocardia. And you can get that from construction and just inhaling and everything you can do from the top, from the bottom. Other things, so, we talked about endemic fungi. Endemic fungi tend to be more granulomas, and this was not exactly kind of a granuloma part. The part of decompensating when you puncture this cyst is where it makes me think more of kind of echinococcus, because it releases a lot of cytokines and makes you go into anaphylaxis. And that's why I was asking for the eosinophilia. We still don't know anything about what the lung looked like, so still there. Thinking of other things that could be cystics, obviously you have some cancers because this is pontine. But TB also would be granulomatous, though there tend to be more mass-like, vasculitis-like.
I do have a question on that, because as soon as Dr. Natasha mentioned that after the fenestration, that's when the patient started being febrile. Would you say that you can put this in two buckets, like something like a echinococcus that released or caused this inflammatory response or anaphylactic response, and also because of the time of the onset of time, we can't just like discard completely and like a hospital infection, right? Like this could be like post-operative, because this patient started like febrile after the surgery.
You could, but I think it's too fast for that. It had to do. So sometimes what happens is that you have a collection or pus or a mass that is encapsulated on a cyst or walled off. Once you break that, you release whatever is inside and can cause a reaction. So it's less likely that this is kind of nosocomial, because it happened very quickly at that time. But, you know, the other thing is the area where it was. I mean, the cyst, you know, did they describe the fluid that came out, Natasha?
Yes. So the fluid that came out was described as murkier than they expected with a simple cyst. Otherwise, immediate notes or immediate reports on the fluid were not available. Pathology from the cyst was also sent and pending.
Yeah, so what you expect on a hydatid cyst is kind of whitish, brownish color, and usually I would have asked at that point to have pathology do a Giemsa stain or H&E to see if I see things like scolex, booklets, anything else that would give me some part. Now, going back to the neurocysticercosis. So neurocysticercosis can also have a cyst. Obviously, here we already know that there's no scolex, so it makes it less likely, but still. So you think of cystic lesions in the brain, you definitely are going to think parasitic. So either, and they're going to be cestodes and trematodes. So cestodes, you have neurocysticercosis and hydatids, echinococcus. Those are the two. There are other worms that can go up on the brain, but they tend to be more mass-like.
That's very interesting. Yeah, because as I mentioned, like sometimes when I'm thinking about a mass, like a brain mass, and situating myself in ID, sometimes I'm like, well, could this be if it's a single mass or if there are many? Because I would think that if it was, for example, toxo, there will be a ring enhanced mass. If it's neurocysticercosis, it will be like many cysts, or like is it valid to like guide ourselves when if we see just one mass or many?
So when you have, so neurocysticercosis can present as a single lesion, a single cyst, but it can also have many cysts. So I would not just say that you only see one and you're not going to see that. Especially when you have viable cysts, you can have a very large one that can kind of produce it itself. Now, cysts will have, that's why looking at the images and looking at what type, if it's water, fluid-like versus a mass-like. And if you look at the T2 on the cerebral, it was pretty white. That tells you that there's water in there, right? Or fluid-like. And so it's not going to be kind of an abscess or a tuberculoma or think that you're going to think that way. So cysts are very, other things that can cause cysts in the brain. Another one that it's rare, but it can be, and thinking about the murkiness, is amoebic abscesses. So it is less than 1% of the time where you can have an amoebic abscess present kind of similar like this. You usually have and it could be chronic. So you could have someone that had dysentery for a long time, and this is an extra intestinal manifestation. So amoebiasis has extra intestinal manifestations. It has a cutaneous one, has a lung, but is usually like an empyema, and in very rare forms has a cerebral part where you could present like that. I mean, he has a weight loss, night sweats and things, but there was no mention of a dysentery or anything like that, but that's always something. So if we have put it on a scale, we look at, let's go back to the case. You have someone that has a chronic illness, right? That we have some clues on the ID history, construction, demolitions, some epidemiology that could have. And then we have now these lung nodules, the wheezing, which could be some eosinophilic part, if you think about, and the double vision that now we know that this was a cystic lesion. So now we have ID causes, ID versus non-ID. So the non-IDs are all your adenomas and cystic stuff like that. Your malignancies. If you have a cyst, you would do parasitics. You would do echinococcus, neurocysticercosis. Very, very low in the totem pole, you would have amoebiasis. If you have, for example, more of a mass, you would go still with endemic fungi, TB, and other kind of weird stuff like bacterial, like nocardia, actino, and rhodococcus and things like that.
Well, thank you so much for this explanation, because I totally had this idea that neurocysticercosis and other like infections would have to be just one mass or just one cyst, but it's interesting to see how it presents out of the literature. So Dr. Natasha, would you give us more information?
Of course. So our next aliquot of information, so a workup is sent along the lines that Dr. Woc-Colburn suggests. So he has sent an HIV viral load, a CD4 breakdown, or a T-cell breakdown, a quantiferon, Bartonella, Q fevers. For endemic fungi, coccidioides, immunodiffusion is sent, antigen is sent, histoplasma urine antigen is sent, cryptococcal serum antigen is sent, and blood cultures as well. As is, I think I said, an echinococcal antibody and a neurocysticercosis serological tests as well. A lumbar puncture is performed, and I can give you those results.
Okay.
Opening pressure is 10 centimeters of water. Glucose is 9. He has a normal serum glucose. Protein is 689. And he has a white blood cell count of 39, with 2% neutrophils and 98% lymphocytes. Additional infectious tests are sent on the CSF and are pending, including culture, including the cryptococcal antigen, and including, AFB, so acid fast bacterial, fungal, and regular bacterial cultures. And then the last part part of this aliquot is his chest CT, which I will try to share here. And I apologize, I picked a representative slice, but I have not worked out how to show all of it. So here is his CT, and you can see that it was sort of called as having diffuse nodules, often a peripheral distribution. So there's one here, here, and here, as well as called as diffuse nodularity and some spiculated lesions, specifically concerning for lung adenocarcinoma, was the radiology read.
Well, he's a smoker. Did they ever do any studies from his did they bronch him or anything like that?
Before, they did not bronch him.
Okay. So you know, as you expect, you have a very low glucose. So what causes can have hypoglycemia? So the first one infections that everybody gets known is TB. The second is overwhelming bacterial infections, because something is eating all your sugar, and that's usually that. The high proteins also goes with an ongoing episode. So he has meningoencephalitis, or an encephalitis, if you want to call it, since you don't have meningitis, with some cystic lesion. I am surprised that it's a lymphocyte. Are they read as lymphocytes and not something else? Because sometimes when they read the lymphocytes, they're mistaken.
They were read as lymphocytes.
Okay. So, and you have only 39 white cells, so you don't have a huge pleocytosis things. So again, your differential, I bet that they sent from the CSF and MTB PCR. They probably did a biofire. I don't know if you
don't actually have biofire at our institution, but a metagenomic next-gen sequencing was.
Okay, so a metagenomic, which is kind of what I like, because it kind of give you all the histories. And then you still can have something parasitic, right? The parasite consumes part of it. So the lungs, I'm not particularly impressed. I mean, he might have an adenocarcinoma, and all of this is red herring, and that's why he has the weight loss and things, and he had a fever, and then that's, we could put that as, remember I said we could have two different things and the lung be a whole part, so that could be the adenocarcinoma and the malaise and the fatigue, and then you have the cystic lesion that happened to be not incidental because it was giving him headaches and double visions, but it led us to a whole different purpose. And so I still, echinococcus, neurocysticercosis, amoebiasis are still part of the differential, as well as MTV part of it.
I'm wondering, with this level of protein, just to be sure, it's 689, right?
Correct.
Would that change? Would that put any like microorganism on top that could cause hypoglycemia, but also very high protein?
So again, you can actually see it in TB. You can see it in parasitic infections. It's you have, what the protein means is that you have a lot of particles that are making it there. It means usually that you have some disruption at the blood-brain barrier where you're leaking more protein, and so you can see that because you're thinking of this other meningitis you had. Also, the LP was done after he decompensated. You just rupture a cyst that you don't know what it was. So that's kind of where we are,
Good, I got it, because I was really puzzled about that. It's very high protein. But let's see what else do we have from Dr. Natasha. I'm wondering, really wanted to know what else is there.
So my question is have I even mentioned the disease?
What test would you like first?
Okay, so I'm going to tell you the Bartonella is going to be negative. The Q fever is going to be negative. Blood cultures are going to be negative.
Correct.
Okay. HIV viral load is going to be negative.
That's right.
Okay. CD4s are normal, as much as normal as you can have.
Exactly. Yes.
Okay. So blood cultures. And so I don't think it's histo or crypto. Oh, so it is histo or crypto. So your TB is gonna be, your TBQ is gonna be negative.
It is negative.
Okay, so so for those that are, okay, so I want to pause before I do. So TB, so your TB quantiferon, we order it is not to diagnose TB. So that is very important because a lot of people order the TB quantiferon saying our diagnosis is active pulmonary TB, and it is not. It only tells you have been exposed, your body has been exposed to tuberculosis. It doesn't tell you if you have active TB or not active TB. So we order it because it gives us another clue into the diagnostic dilemma if there's something could be TB, but it's only to diagnose if you have been exposed. So that's my kind of teaching pearl. All right. So neurocysticercosis is going to be negative. That probably took like eons to get.
It did.
Did you send it to the CDC or did you send it to the NIH?
I believe it was canceled because another test resulted positive and gave us a different diagnosis.
Okay. And so the neurocysticercosis, so for you to know, it's an antibody. It is made out of crude cysts. It's not reliable enough. If you have neurocysticercosis and you want to follow, I usually send it to the NIH with Dr. Elise O'Connell, and it's actually a PCR of antigenemia. So it actually measures, as you treat the patient, it measures your antigen in the blood and as well in the CSF. And that comes into play when you have very difficult cases of neurocysticercosis. So that's kind of another part. All right. So that leaves me with, the jack of all trades with our endemic fungi, which are crypto, histo, and coccidio. So, yes. Which would put, if we put that together with the adenocarcinoma that got misread, construction worker and things, I would go bird droppings, crypto first, histo, and then coccidio. And again, was
Wait, what was that?
We still have the Echinococcus that is not back yet because it's going to take 3 weeks to come back.
Yes, that is still out and it has not come back.
So that's what I'm telling you. It takes you 3 weeks and it's never going to come back.
Which is very frustrating. But in the meantime, the coccidioides complement fixation comes back negative, the immunodiffusion comes back negative, and the antigen comes back negative. The histoplasma antigen comes back negative, but the cryptococcal serum antigen comes back positive at greater than limit of assay, so greater than 1 to 160. And it is added onto the CSF, which comes back at 1 to 1,280. And finally, the pathology from the cyst comes back concerning for fungal forms. Broad range PCR is sent on the cyst, in addition to the metagenomic next-gen, which is pending, beg pardon. And the broad range fungal PCR results positive.
Did it grow in the culture?
It did not grow in the culture, but the PCR...
So I'm going to pause you there. So and pull the how many people thought that the crypto would grow on a culture? I can see hands, but let's say so let's see if are you surprised that the Cryptococcus did not grow in the culture? Should I say that's yes or no? Let's hear it. Do you think that the crypto should have grown in the culture? I do have a point here.
My understanding is that Cryptococcus needs a special attention and special like ways to find it. If it's not, if I'm not wrong, India ink, but I'm not.
So no, so the India ink, so India ink, we don't use it in the US that much because we have better things. But it is used all over because if you remember, Cryptococcus as well as histoplasma have a capsule, and the idea of the India ink is to show the capsule. So with what Natasha is telling us and what we know so far, so it has a high antigen of 10 to 80. You have high protein. You have a lot of glucose. So you have a high burden of disease. You're actually not going to grow the Cryptococcus. It takes a long while. And actually, we see this in our AIDS patients with severe Cryptococcus that we don't grow it on culture. So about 15 to 20% will not grow crypto in a culture, and the media that we use, which is the same media as other things, is called Sauron. And Natasha, it did not grow on the cultures, on the fungal cultures, because with this high burden, sometimes we have Cryptococcus in the blood cultures.
It did not. I will also say that one last piece of data came back, which was the speciation.
Mm-hmm.
Both the metagenomic next-gen and the PCR from the cyst itself came back positive for Cryptococcus gattii.
Yeah, I was going to say. And it's because of the region you are.
So this is a regional disease, and it also, I was really surprised to get this test back, and it, I think, helped to explain why we had a gentleman without HIV with this diagnosis.
So Cryptococcus gattii is predominantly from the Pacific Northwest. You see it mostly in Vancouver, in the island of Victoria. And it comes from the little eucalyptus trees that got imported from Australia, which is the other place that you see that. And kills the little koala bears, by the way. So Cryptococcus gattii is, so you have Cryptococcus neoformans, and so there you have different variants, and so this is variant gattii. It is an aggressive, indolent, endemic fungi. And I said indolent because it takes a long while unless you're immunosuppressed, and can be very devastating to form that, So, and that's why you would have this high protein, you have your low sugar. So clinical pearls, low sugar, TB, endemic fungi. The other part is that's also because of this high burden of disease, you're not going to see a lot of inflammation. And that's why your WBCs didn't give you a lot of pleocytosis, because it was walled off. And usually Cryptococcus stays on the arachnoid, and causes an arachnitis more than an encephalitis. And so you don't see a lot of inflammation, but you can see a lot of protein because of that breakdown on the brain-blood barrier.
So that would make sense of why the patients are febrile after the neurosurgeons did the fenestration, right? But what really puzzles me is I would like to know, like, how is this Cryptococcus gattii on a non-immunosuppressed, like non-HIV patient?
So Cryptococcus, just like any other endemic, just like Cryptohistococcidio, right? Are not, or paracoccidia. You don't have to be HIV to acquire. You inhale it through the nose. And so this is where, if you remember, Natasha told us that there was rodents, bird droppings, and he worked in a construction. That's kind of that's kind of the epidemiological clues, right? So you inhale this, the bird droppings, you inhale, it becomes aerolized, right? So there's in a constructions, things are being knocked down. There's like bird flying around and dust, and you inhale that dust, and it goes to your lungs, and those are the lung nodules, and then it becomes disseminated through the body, and it goes to your brain. Crypto is can also give you prostatitis, colitis, hepatitis, endocarditis, osteomyelitis, all the itis.
Oh, wow.
It is actually a fascinating disease, but yeah, so it can do that. And treatment, you know, is ambisome and flucytosine as induction, and then fluconazole for a long time, usually a year.
Oh, I really didn't know that crypto could do all of those things. I'm wondering, Dr. Natasha, do you have like a resolution of this patient? What did you do with him?
Yeah, of course. I mean, so firstly, that was fantastic explanation. I first of all was so puzzled because I'd never seen a case of gattii, and as far as I knew, it was only in the Pacific Northwest. Since then, I've realized that it's a little bit more widespread, which is an uncomfortable thing for me to know. And I've since seen several cases at our institution here in Northern California. I learned that smoking is a risk factor for developing disease. And I also learned that it often is more likely to form these cryptococcomas, which is eventually what that cyst was diagnosed as. So our patient was required a VP shunt for hydrocephalus. He was, as Dr. Woc-Colburn mentioned, induced with liposomal amphotericin and flucytosine, and then transmission to fluconazole. Unfortunately, 2 months later, he had clinical worsening in terms of his mental status and a recurrence of headache. He was readmitted, reinduced with 6 weeks of amphotericin and 5-FC plus steroids for an inflammatory response. Finally, after that, transitioned to posaconazole because of issues tolerating fluconazole and a very long steroid taper. He is now on posaconazole maintenance therapy with no current plans to stop it, but is clinically doing well.
So one thing, Natasha, is you should submit this to the ID Week, which is in LA this year, as one of the cases for the Fellows Days conference, and so because of its complexity. So the other thing is for Cryptococcus in non-HIV. So in HIV, we do shunts or serial LPs, and usually the shunts are better. But we have learned that the shunts actually can get plugged up, which could have happened with this patient because of that high protein that the patient has. So the reason there is a hydrocephalus is, if you think of the brain that is a box, it's the Monroe Kelly. So the brain expands and you have fluid. The fluid has to be absorbed. And you absorb that fluid through the arachnoids. And so if you have arachnitis, the inflammation, you actually are, it's not just inflammation, but that capsule, that is the protein that is being produced here, that capsule actually stops you from absorbing. So think of a sink, and I don't know, you put a lot of grease on it or something, and the water doesn't trickle down and just continues to grow. So that happens on the shunt, the same thing. Those shunts sometimes can get plugged up because of the high protein that is being produced. So you actually have something that is stopping and not being able to do. So the idea of reinduction is to try to lower down the disease, because you have a burden of disease that you're not able to go down. The beauty of an HIV/AIDS patient is that as you give the medicine, the body can get rid of that. But this is not the issue in this patient because it has a normal immune system. So it produces more protein. And that's why it plugs them up. Now, the case of posaconazole, I've seen patients who have a high burden of disease, and we talked about this because, it didn't grow, it had a high titer and was all over the place, and it was forming a cyst. Is that they actually become resistant to fluconazole, or they become intermediate, and that's why you switch them to posaconazole. So even though, and that's why you reinduce for so long, that the idea of putting in a 4 to 6 weeks is actually to decrease the burden of disease, because you're not getting enough levels inside and letting the body kind of clear all that muck that you have actually in your brain. When I had to treat some patients that had, they were done because they were on monoclonals for multiple sclerosis, it took them 6 weeks to actually clear out. One actually improved, and another one had a lot of brain cognition and paralysis to them. So, so that's my caveat on that. There was a question on the chat. Oh, okay. So, can I go to this ID week? Yes, you can go to the ID week. Just apply. I mean, anyone can go to ID week. It's in LA. If you're Latino, we have a fun night, and we also have Jeopardy. But now going to the question, how to differentiate cryptomeningitis versus cryptoiris if Cryptococcus fungal is negative? Well, so it's actually what's going on clinically. So if you have a patient that has never been on ARVs, and you come in and you diagnose the patient, you can have cryptomeningitis. You're going to have iris as you start reconstituting the immune system, and that's when you start your HIV meds, or you decrease your transplant meds. Having a negative culture doesn't tell you if the active disease. Also, in HIV patients, and more in HIV, we don't follow Cryptococcus titers because they're all over the place. Once you diagnose one Cryptococcus titer, you don't kind of follow like syphilis titers to see if they can actually decrease, because they can go up and down. That is not the case in non-HIV patients, and we don't know why. But you know, it is weird. And like, so in this patient, you know, you could probably follow the titers, and according to titers, go looking from them, opposed to our HIV patients.
Oh, thank you so much for answering that question. Very, like, honestly, this case was mind-blowing. I personally enjoyed so much the part when Dr. Laila was like, this won't be positive, this won't be positive, this, I'm pretty sure it's this. So that was an amazing, amazing discussion, Dr. Laila. I'm wondering, Dr. Natasha, any other like teaching pearls you would like to share?
Sure. I think I learned a lot about gattii from this, and the first thing I learned was to be very afraid of it. I think we don't fully understand where it is, and as we're getting more sophisticated diagnostic tests, perhaps things that we thought were neoformans are in fact gattii, especially when it's doing things that we, quote, don't expect. So attacking people who are not immunocompromised, as this gentleman was not, or at least not classically, or causing severe disease with these like cryptococcomas in the brain, or being very challenging to treat. I learned a lot about the where it's found, because my first thought was, you know, why is it affecting patients here in my sort of backyard, from both the CDC and the literature. And sort of came across a really fascinating hypothesis that I don't think I'm qualified to judge, but there's a really interesting idea that ships from other areas brought it to the offshore waters near the Pacific Northwest, and it was then carried inland by a large Alaskan tsunami that took place in 1964, thus eventually leading to this outbreak, which I'm not qualified to judge that hypothesis, but found it completely fascinating. So I learned so much from this case and from caring for this patient, and I'm incredibly appreciative of both Yasmin's amazing facilitating and Dr. Woc-Colburn's incredible discussions.
Thank you so much. Honestly, I really appreciate ID topics. Laila, thank you for being here. And before we finish the session, I will ask our friend Amalpreet to give us her most favorite teaching points, which I know is very difficult to choose. So yeah, Amalpreet, let us know.
Thank you so much for this amazing case and amazing teaching points, and I absolutely loved it, and I'm honored to just share my what I learned from it. The first thing I loved was listening about idiopathic CD4 syndrome, where they said that patients can have low CD4 counts, but we can detect that it can have negative HIV test, normal viral load, but we can have low CD4 count in that patient. The patient can have many infections, so that was very interesting. And even HIV test is not reliable, we go for viral load. And secondly, I loved when diplopia was considered. So we got over to some intracranial mass, which would be compressing the optic chiasm. That came into our differential. That was an interesting point in the case. And I loved talking about the Cryptococcus gattii, which is common in the Pacific Northwest, Vancouver, and smoking is a big risk factor in this patient. And it can cause various types of itis like prostatitis, osteomyelitis, colitis, and endocarditis as well. And another thing that its treatment is liposomal amphotericin, flucytosine, and fluconazole. And the shunt can get plugged up due to high levels of proteins that are produced. So they were some of the interesting points I learned from the case. So thank you so much for that.
Thank you. Those were amazing. And Dr. Laila, again, thank you so much. If it was for me, we will be spending the whole evening talking about ID. Thank you so much. Being mindful of your time. We have reached to the end. I hope we can have you another time soon.
No, thank you for having me. It's always a pleasure. This was an incredible case. Thank you, Dr. Natasha. As I said, I encourage, to send it to the ID week because I think it has a great points. And as I said, this year is going to be in LA. So gattii, and I know that my friends who are the fun guys, I know. Anyways, love this and we're looking at it. But as I said, crypto, it's like any fungus, keeps on giving things. And I think it's fascinating what we do. And no, thank you for having me. And I hope that it helped a little bit and in my scatterbrain on how I think these things throughout when I have difficult cases.
It was great. So thank you so much. Thank you, Natasha. Have a great evening.
Thank you. Bye.
Thank you.